part 2. This is the Assure Educational Foundation, and I am Dr. Prithiviraj, dealing the surgical gastroenterology in hepatobiliary surgery, along with other friends of mine. So last class we covered the anatomy in a short. This is a question-based mock class, and it is similar to the previous mock class. So if you have any doubts, you are always welcome to ask in between the session, or you can note it down and you can ask it at the later part. So coming to the liver blood flow. So this is a recap of what I have told in the last class. So as we know, the total liver blood flow is 800 to 1200 ml per minute, and it is like 100 ml per 100 gram of the liver. It is 25% of the cardiac output, and the 20% of total oxygen consumption of the body is by the liver. So coming to the hepatic artery proper. The hepatic artery carries 25% of the total blood flow to the liver. It's a high pressure and high resistance system, and the blood flow is in the range of 30 ml per minute per 100 gram of liver tissue, and it provides 50% of oxygen requirement to the liver. So this supplies exclusive blood supply to the bile ducts through peribiliary plexus, as we all know. And there are some extrahepatic and intrahepatic collaterals. This I had discussed previously in the previous mock class. And coming to the portal vein, it gives 75% of liver blood flow, that is 90 ml per minute per 100 gram of liver tissue. And it also provides 50 to 70% of the oxygen requirement of the liver. So coming to the hepatic veins, the main points we have to remember is the pressure in the hepatic veins is just 1 to 2 millimeter. And the pressure gradient is in the range of 5 millimeter of mercury. And this is similar to the HPB, that is hepatic venous pressure gradient. That is also in the range of 5. So let's go into the questions as a part of this mock class. So I'll put up a few questions, and once we'll read up the questions, and we'll try to find the answers, and finally we'll discuss which is right and which is wrong. So coming to this, so false regarding hepatic microcirculation. So the classic lobule emphasizes the endocrine function of the liver. Portal lobule is based on flow of bile to the portal triad. Portal acinus is based on blood flow from portal venule to the central lobular vein. And pericentral zone is exposed to lowest nutrients in blood. So this is based on the hepatic microcirculation. As we all know, the classic lobule is the most commonly used term before, but it has been further subdivided, and let's see how it has been divided. So you know the microscopic structure of the liver. There's the hepatic sinusoids, and this is the roughly hexagonal with a central lobular venule, and the portal triad is in the periphery. So if you see the portal triad, it consists of the hepatic artery, the portal venous branch, and the bile duct branch. And can you see this encasement? And this is encased in a group of cells, and this space in between this portal triad vessels and this lining is called as the space of Mall, M-A-L-L. And we all know that the hepatocytes are arranged in roughly linear and hexagonal fashion, and the sinusoids are in between them. And between the sinusoids and the hepatocytes, we have this space of Dicey. So this portal vein drains into the central lobular vein, and the exchange of all the nutrients and oxygen takes place down this portal vein to the central lobular venule along the sinusoids. So this is a pathological picture that is represented. So coming to the hepatic microcirculation proper. So if you can see the classic hepatic lobule, just a minute. It is divided into 3 types now: the classic hepatic lobule, the portal lobule, and the portal acinus. And just bring this. So the classic hepatic lobule was the one initially that was followed. So it is like, just a minute. It is like based upon a central lobular venule in the center and 6 portal triads that are around, and it is roughly a hexagonal shape. And the portal triad is formed by a terminal branch of hepatic artery, portal vein, and bile duct, as you all know. And it is encased within a limiting plate of cells defining the space of Mall, as already depicted. So coming to the classic lobule model. So the classic lobule model is based on emphasis on the endocrine function. So it emphasizes the endocrine function of the hepatocytes as the blood flow pass them towards the central lobular venule from the portal triad. So coming to the more functional portal lobule, so this was based on the flow of bile, and actually it is like the bile is flowing from here into roughly 3 central lobular venules, and which is roughly a triangular space. So the portal lobule is based on flow of bile from these regions, from the region of 3 classic lobules towards the bile duct in the portal triad at the center. So this is like from here, it is draining into the bile duct. It is the reverse. Actually, the flow of artery and vein is in this direction, but the flow of bile is in the reverse direction. And the area drained by a portal lobule is roughly triangular in shape. So the portal lobule is based on bile flow. Okay. So classic lobule is based on the endocrine function, and here the blood flow goes from the portal artery and vein into the central vein. The portal lobule, as we saw, it's an exocrine function, and it is based on the flow of bile from the hepatocytes into the bile duct. So coming to the last, the portal acinus as depicted by Rappaport. It consists of 3 zones, and it is based on the oxygen and nutrient gradient. So we have the zone 1, which is the most oxygenated, which is near the portal triad, and we have it is also called the periportal zone, and we have the mid zone, that is the zone 2, and the third zone is the pericentral zone, that is zone 3. So as we all know, the oxygen decreases when we go towards the central vein, as do the nutrients. So what is the answer? So false, which is the false one? So classic lobule emphasizes endocrine function, that is correct. The portal lobule is based on flow of bile to the portal triad, that is also correct. The portal acinus is based on blood flow from portal venule to central lobular vein. No, that is actually the classic lobule. The portal acinus is not based on this. It is based on the oxygen and nutrient gradient. And coming to the pericentral zone, the pericentral zone is exposed to the lowest nutrient in the blood, and that is also correct. So further going to explain the microcirculation, we should know about the hepatic sinusoids. One of the most important cells in the hepatic, in relation to the hepatic sinusoids, are hepatic stellate cells. The other names of hepatic stellate cell is the hepatic stellate cell, or the Ito cell, or the fat storing cell. So in the hepatic sinusoids, the basement membrane is absent. There is a unique lining consists of an endothelial cells. So these endothelial cells are not are porous, containing flattened processes perforated by small fenestrae. So these fenestrae, they are arranged in clusters of 10 to 50 pores. So they form similar to what we call the sieve plates. And the diameters are like approximately 150 to 170 nanometers. These pores decrease in diameter, but there is an increase in frequency when you go from the periportal to the central lobular zone. So in the central lobular zone, there is high porosity, but the diameter is decreased. Okay. And the most important factor about this hepatic stellate cell are their contractile in nature. They are the main role in regulating blood flow through this hepatic sinusoids, because they are contractile in nature. And there is another point that I will discuss in the next question. And these hepatic stellate cells have proposed to have a role in the fibrogenic response. So this is the diagram showing the relation of the hepatocytes to the hepatic sinusoids, and the space between is a space of Deci, and which contains the hepatic stellate cells. As you can see, these cells are the Kupffer cells, which are the macrophages, as you know, liver-specific macrophages. You can see this endothelial cells, there's fenestrae, and these form the sieve plate. So there is an interaction between this hepatocytes, these endothelial cells, and the hepatic stellate cells, and direct secretion of these vasoactive mediators goes into these hepatic sinusoids, and thereby they exert a action on these hepatic sinusoids, which we will see later, and what are the effects of it. So coming to the next question. So what is the hepatic artery buffer response? So let's find out and say which is the false. The hepatic artery flow increases up to 50% from baseline on portal vein decreased flow or occlusion. It is adenosine mediated. It is capable of buffering 25 to 65% of decreased portal flow. The hepatic artery consists constricts with increased portal vein flow. And the final option is portal vein flow does not change with response to hepatic artery flow. So let's go into the detail of this hepatic artery buffer response. So this is the most important intrinsic blood flow regulation in the liver. So this is the hepatic artery buffer response. Hepatic artery buffer response is nothing but the compensatory flow change in the hepatic artery at the pre-sinusoidal level. So if you see the hepatic artery, it can the flow can increase from up to 0 to 30% from the baseline based upon the decreased portal flow or occlusion in the portal flow. And this hepatic artery dilatation is actually adenosine mediated. And it is also capable of buffering 25% to 60% of decreased portal flow. On the contrary, with increased portal vein flow, the hepatic artery can constrict and the blood flow can be decreased when there is an increased portal vein flow. And this is called the hepatic artery buffer response. The most important point to note is that vice versa does not occur because the portal vein flow, there is no changes in response to the hepatic artery flow. In cirrhotics, the hepatic artery buffer response is still maintained, but it is markedly diminished. As you can see in this picture, in this flow chart, we can see that with respect to the blood flow, with increasing blood flow in the portal vein, there is a decreasing blood flow in the hepatic artery, and this is a graph of a cirrhotic and this is a graph of a non-cirrhotic. As you can see that the variation has been decreased very minimally in the cirrhotics, but still it is maintained. And this can be also a question where they can say that the hepatic artery buffer response is abolished in cirrhotics. And a similar question is also there where they say high pressure laparoscopy nullifies the effect of hepatic artery buffer response. That is also incorrect because even in high pressure laparoscopy, the hepatic artery buffer response is maintained, and this can also be a question for you. So what is the false statement? The hepatic artery flow increases only up to 30% from the baseline and not 50%. And the other things are correct. So coming to the next question. So intrahepatic vascular resistance. So find out the false statement. See, each of this topic is a bit vast and it is self-explanatory. But going into the details is not the scope of this mock class. So we'll be covering this in the next coming classes. So what is the false statement? Hepatic inflow is not controlled by liver intrinsic metabolic needs. The autoregulation in the liver is smaller than other organs. The hepatic stellate cells and sinusoidal endothelial cells regulate intrahepatic vascular resistance. Smooth muscle cells with sphincter-like mechanism regulate the flow rate. So you must have guessed from the previous discussion that the hepatic stellate cells and sinusoidal endothelial cells regulate the intrahepatic vascular resistance. So at least we know that one is correct from the previous slides. So if you can guess, you make a guess. I'll just explain it to you now. And the other point is only hydrogen sulfate has been shown to have a direct role. So find out the false statement. So there are questions like somewhere like only, which will tend to make you that this might be the false statement. But let's find out whether this is the false statement or which one is false. So the intrinsic blood flow regulation, apart from the hepatic artery buffer response, the intrahepatic vascular resistance at the level of the sinusoidal level is also important. Because the hepatic inflow is not controlled by the liver intrinsic metabolic needs, and it is the main autoregulation that is higher in other organs is smaller in liver, and in fact there is very little change with the flow by the liver's intrinsic metabolic needs. So coming to the intrahepatic vascular resistance at the sinusoidal level, both the hepatic stellate cells and the sinusoidal endothelial cells may regulate the intrahepatic vascular resistance, as I already told you, with the release of vasomediators into the sinusoids and spacer DC. And it has been shown experimentally that only hydrogen sulfate has been shown to have a direct role. And they have tested with others like nitric oxide, endothelin 1, and these have not shown a direct causative role in intrahepatic vascular resistance. So the answer is smooth muscle cells with sphincter-like mechanism regulate the flow rate is a false answer. There are no smooth muscle cells, and there are some few smooth muscle cells, but there is no sphincter-like mechanism. And it is supposed that the hepatic stellate cells contract, and in turn they make the endothelial cells contract, and this is mainly by the mediation of vasoactive agents. So what are the extrinsic factors that affect the liver blood flow? So we have seen the intrinsic factors. Now we are going to see the extrinsic factors. See, these topics are a difficult topic because it is more of mugging up rather than reasoning out. A few can be reasoned out, and it is better that you have some basic idea of how the flow is, liver blood flow is, and what are the important changes that occur, so that you need not mug up everything, and you develop a concept. So coming to the endogenous factors, hypercarbia and metabolic acidosis, they increase the portal vein flow. So obviously, portal vein flow increases, the hepatic artery will decrease by the hepatic artery buffer response. In hypocarbia, it is entirely different, where both the portal flow and the hepatic artery flow is decreased. So this is a important point you'll have to note. And in hypoxia, there is decreased hepatic artery flow, but there is no change in the portal vein flow. And metabolic alkalosis, there is no effect. So coming to the sympathetic system, there is no direct role as we see, and the hepatic artery vasoconstriction is due to autoregulatory response. So coming to the next, endogenous vasoactive agents, glucagon, there is a profound increase in hepatic flow in glucagon. In nitric oxide, histamine, prostaglandins, except for prostacyclin, there is an increased hepatic artery flow. Coming to the anesthetic agents, as we know, fentanyl is very commonly used in patients with liver diseases, and isoflurane and sevoflurane, because the normal agents that we regularly use, like nitric oxide, halothane, and enflurane, they cause a decreased hepatic artery and portal venous flow, and that has a marked effect whenever they are doing liver surgeries. So coming to the final question of this mock session, which of the following is used to measure hepatic artery tissue perfusion? Transient elastography, indocyanine green excretion, laser Doppler flowmetry, and reticuloendothelial cell uptake by technetium sulfur colloid. See, making a rough guess is not possible in questions like this. So it is better not to attempt questions if you do not know. But these questions are usually picked up from tabular columns, and you need not even read in detail, because this has been explained for like about 3 to 4 pages in Bloomgard. But there is a small tabular column that is given. And once you remember at least a part of it, it is easy that you will understand how this goes about. So coming to the liver blood flow measurement, the summary of the methods to assess a flow in a single vessel, we can use this electromagnetic flow meter or Doppler. So total liver blood flow is usually measured in terms of these excretory methods, where we can use indocyanine green or galactose by reticular endothelial cell uptake of sulfur colloid. Indicator dilution method is where when you put an indicator into the hepatic artery, and the amount of dilution is directly proportional to the amount of blood flow, and this is based on fixed principle. And the other thing is indicator fractionation is nothing but radio-labeled microspheres are injected, and depending upon the detection of microspheres, we can reduce the blood flow. So finally, coming to the hepatic tissue perfusion. So inert gases, see, as we all know, inert gas, they do not have any change in diffusion across any tissue. So the inert gas is equally distributed. So when you see in the liver tissue, depending upon the distribution, we can calculate the blood flow. The other is laser Doppler flowmetry, in which a laser light is used, and depending on the changes, the velocity, the hepatic tissue perfusion can be identified. So the common clinical use are indocyanine green, the Doppler ultrasound, and the technetium sulfur colloid. So clinical relevance of knowing the liver blood flow is to understand the pathological conditions like shock liver, ischemic preconditioning, which is made by the heat shock proteins, the changes that occurs during the biliary obstruction, and the post-liver transplant blood flow changes. So, and finally, so what is the answer? So to measure the hepatic tissue perfusion, we use laser Doppler flowmetry. And other things are used in this indocyanine green and sulfur chloride are used for blood flow, total blood flow, and transient elastography also. So I would like to conclude my session. So if there is any questions, you are welcome. So these two, the mock class topics are actually vast topics that we have tried to concisely cover, so that you will be benefited by understanding how we go about and how we take the classes. So I'm going to stop sharing my screen. So if there is any doubts, you can please go ahead and ask. Now, if there is any suggestion, you are welcome to put in the chat box. So the Mark 1 and Mark 2, actually they are like, the entire topic can be covered by in like 1 to 1.5 hours, the entire topic that has been discussed in Mark 1 and Mark 2. It is just a part of what we are going to go about. So we'll make changes of how you will require in further classes. You can give suggestions. Previous questions can also be discussed. And even after the end of the session, if you want a small mock test in a regular class, that can also be done. So there is no further doubt. Can we end the session?